Hello everyone. Now I'll discuss question of pediatric. So we have a 5-year-old boy brought to you for a routine checkup that and the report given to you is the child has been sleeping longer than usual and often into the afternoon on weekends, and now he wake up in the morning. He has a morning headache throughout his head. Visual acuity is decreased bilaterally. Skin reveal numerous freckles in the axilla and 8 flat small uniformly hyperpigmented macule on the trunk. This is following this is a best next step in the management of this. Well, it's a lovely question. You are getting a child having freckles. The answer is brain and orbital MRI. Why this answer? What the problem the patient has? Patient has neurofibromatosis type 1 NF1. It is an autosomal dominant condition. In fact, it belongs to category of the disease so-called neurocutaneous syndrome. Now, just to add on to your knowledge, all neurocutaneous syndrome they are all autosomal dominant condition. Many of these I'll be discussing in this question also. Well, now caffeolate spot, they are the earliest manifestation. They are the macules which may even appear in the infancy also. Skin macules, coffee color. With increasing age, as the child grows, there will be axillary or inguinal freckles. Freckling, what they call as. In this child also, the child has freckling. Leash nodules and neurofibromas, which are nothing but benign peripheral nerve sheath tumors, they develop, and this child also already has developed neurofibroma and axillary inguinal freckling as given in the question also. Okay. Well, now as far as these skin condition are concerned, neurofibroma or caffeolate spot, these are also patient of NF1. They are also in the risk of developing intracranial tumors. Okay. Well, let me show you picture. What finding we can get in a patient of NF1? We can get optic glioma. We can get leash nodule. I'll be discussing these. Caffeolate spots. Scoliosis can be there, and neurofibromas. You can see lovely picture of neurofibroma, and there can be pseudoarthrosis can be there. Okay. Well, they're the finding that we can see in our patient. They talked about caffeolate spot, neurofibroma. They talked about, and they were talking something about some visual acuity is disturbed and headache is there. Let us see why it is there. So, as I told you in the previous slide that these patients can develop intracranial tumors. There are increased risk for astrocytoma and brainstem glioma. Even in adulthood also they can develop. So other than optic glioma, these tumors can be there. Now this patient has early morning headache and vision disturbance. Early morning headache with vomiting is one of the features of raised intracranial pressure due to whatever reason it may be. It simply indicates raised ICP is there. It never indicates that tumor is there. There are so many causes of raised ICP, but brain tumor is one of the cause of raised ICP, and this to raise ICP, the child is developing early morning headache, vomiting, vision disturbance. They are the really matter that patient may be having certain intracranial mass, and that also we know by physical examination we have confirmed most likely patient has NF1. So it is mandatory that we go for MRI of the brain and orbit to rule out intracranial structures or any malignancy. Now, what are the most common intracranial tumor in NF1? I did mention to you that there can be many tumors in the brain, But which is the most common? Well, the answer is optic pathway glioma is the most common malignant tumor of NF1. Okay, and it typically happen during toddlerhood. Like our patient, he's a patient of only child of about 8 years. Well, it may be asymptomatic, but a growing tumor can cause headache and decrease visual acuity. Okay, headache is often worse in the morning because of raised ICP, worsen as overnight while supine. So as I told you, any headache and early morning vomiting may indicate raised ICP like in this patient also. Now let's look into other options that we have. Audiometry. This bilateral acoustic neuromas, so-called vestibular schwannoma, they may cause sensory neural hearing loss. And they are diagnostic of NF2. Audiometry is the best initial screening test if you are suspecting any acoustic neuroma, maybe unilateral, bilateral, but definitely patient of NF2 do not have capillate spot and axillary freckling. They don't have. So this is not a case of NF2, and moreover, acoustic neuroma they are not the part of NF1. So there is no point in doing audiometry in this case. Electroencephalogram, so-called EEG. Patients with NF are increased risk of epilepsy because of any mass in the brain. But still, it is not the first investigation because the primary problem is of not seizure. Seizure can occur due to so many reasons. Okay, so when we are suspecting intracranial mass, the first investigation is always MRI. In fact, it is true for any seizure patient come and you are suspecting certain mass or secondary cause is there. In any secondary cause, well, secondary cause of seizure could be any mass, it could be any electrolyte disturbance or any other reason. So always rule out secondary cause of seizure. Primary is idiopathic. So it's mandatory that you rule out secondary cause of seizure. But in this case, we already have a strong indication that we are dealing with a mass, intracranial mass. So MRI is preferred over EEG. ESR, erythrocyte sedimentation rate, ESR, is an acute phase reactant, non-specific. It is raised in so many conditions. Definitely, it is not going to give a clue why the patient has headache and vomiting, visual disturbance. It is not. It's a totally non-specific investigation, not needed. Lumbar puncture we normally do to rule out any infection, especially, rather we can say even infection also, specifically we talk about meningitis. Now patient of meningitis will have fever, headache, photophobia, rigid neck. It's altogether different presentation, but these findings are not there in our case. So definitely our diagnosis is nowhere near the meningitis, and definitely meningitis in particular we do lumbar puncture. And now if the patient has brain tumor, if you do lumbar puncture, it rather carries the risk of brain herniation. There may be raised ICP, and raised ICP is a contraindication of doing lumbar puncture. Okay, so of course, even in case of meningitis also, we have to rule out raised ICP by CT scan. Never do lumbar puncture with raised ICP. So space occupying lesion SOL should be suspecting in this patient due to morning headache, and that's why meningitis is no way, lumbar puncture is not indicated in this particular case. Well, golden line to remember, that patient with neurofibromatosis 1 are at increased risk of developing optic pathway gliomas. They can present with headache and decreased visual acuity. MRI of the brain and orbit evaluate for an intracranial mass. Okay. Thank you very much.